So this is about sleep disorder and obstructive sleep apnea. And there's some accompanying videos that I made on how to use the NightLase procedure, because that's really what this is about. And I've written a couple blogs in May of 2022 that you can look at for some statistics and references. So we're going to talk about implications for health of sleep disorder and evaluation and treatment. Sleep disorder is a broad term for snoring or disturbed sleep. And sleep apnea, obstructive sleep apnea, is where people actually have an abnormal score on their sleep apnea test. Most people are really never tested. So snoring is pretty common. Occasional snoring affects the majority, not the majority, most people, a little bit more than 50%. And habitual snoring is where it's kind of regular. People snore regularly. It's about 9% of women and 30% of men have habitual snoring. It's to the point where 9% of men have snoring severe enough that their partner leaves the room at night, and 2% of women have snoring that's that degree. So it's going to have an effect on quality of life. Obstructive sleep apnea, we don't have clear data because not everybody gets tested. It's estimated only about 20% of people with sleep apnea get tested and diagnosed, and only about 25% with severe obstructive sleep apnea ever get diagnosed and then therefore not treated. But the incidence is thought to be about 22% of men and 17% of women. But when you adjust it for age over 30, it's about 26% of adults. And it gets higher as we get older, and certainly higher with other comorbidities such as obesity, diabetes, cardiovascular disease. And it's defined as an hypopnea score of greater than 5. And we'll talk about that. So there's an apnea screening test, and this is the 1-minute apnea screening. There's 3 different tests. You can ask these questions. Do you snore loudly? Do you often feel tired, fatigued, sleepy during the daytime? Has anyone observed you stop breathing during your sleep? Do you have high blood pressure? Is your BMI greater than 30? Are you greater than 50 years old? Is your neck circumference greater than 15 3/4? Are you male? And if you say yes to 3 questions, you're at high risk for sleep apnea. I actually have 4 of these. My neck is 18 and a half inches. I'm male, 50 years old, and I've had high blood pressure. But I don't have sleep apnea. AHI score. So we first do the hypopnea score. A normal sleep score is having less than 5 events per hour, and less than 5 times per hour of having apnea or hypopnea. Mild is 5 to 14 per hour, and moderate is 15 to 29, and severe is 30 or more events per hour. This is done with a sleep study. Now, this score is reported that way. It'll say AHI of 27, and that would mean that you're moderate to almost severe. And a sleep study can be done in a sleep study lab where you go to a clinic and sleep, and they watch you, and they have these monitors on you. And that was traditionally done. It was very expensive, and it's kind of difficult to do, sleeping in a different environment. I can't imagine sleeping in when somebody's watching you. But now most of the sleep studies are done at home. There's little devices that you wear that measure your oxygen and your breathing. There's little sensors. So it's mostly home-based testing. An oxygen desaturation index is also picked up on the sleep study, and that's how many times you desaturate for greater than 10 seconds in a night. So for sleep evaluation, there's certain risk factors, there's sleep patterns, drugs and alcohol, and that's really something that should be done in the purvey of their family doctor or a sleep specialist. We're not going to be working on trying to figure out why they have sleep disorder or if they have it. This is more of a screening that we may offer and a treatment that we do currently offer. Mallampati score is a common score looking at the back of the throat, and there's classification. 1 is where you can see everything. 2 is you can see the uvula. 3 is you want to see part of the uvula. 4 is the uvula is in the soft palate not visible at all. People can have sleep apnea with any of these classes, because now we know many people have sleep apnea because things slide back when they lay down flat. But this is something you might score. I take a picture of the back of the throat with the patient with their mouth open. Not saying just mouth open, and many people have significant snoring will have higher classifications, but that's not mandatory, but we should look. So the treatments, for people with mild disease, they might use dental appliances, or even these nasal expanders that go in the nose that lift it out to open the airway. CPAP, that's a device that you wear at night. It's usually nasal and oral, depending on how you breathe. And there's different types. There's continuous and BiPAP and different things. They have costing from $250 to about $6,000 based on the type of CPAP you need. The machines only last so long because they do degrade over time. There's a surgery called Inspire, and I'll talk about that later. That's an implantable device that stimulates the hypoglossal nerve to make you breathe at night. And then there's surgery, which is really just here for reference purposes. The surgery is pretty much not done, it has too much complications, and it's just not that effective. So the health impact of snoring, this is not sleep apnea, it has a better quality of life, better sleep, and for both the patient and partner. So the reasons that we want people not to snore so much, again, we said a higher incidence of men and women snore habitually. Impact of treating apnea is much more. So in American Heart Association has a scientific statement, and they identify that apnea is underdiagnosed. It's probably only diagnosed in about 20% of people. A little bit more, maybe 25% of people with severe apnea. So it's not picked up enough by the doctors just aren't considering this in their patients that aren't complaining about sleep apnea. Apnea significantly impacts morbidity and mortality. We'll get into that a little bit later. And all patients with obstructive sleep apnea should be treated. So the American Heart Association statement says all patients with obstructive sleep apnea should be treated. The general qualifications are people with severe should be treated with CPAP. People with mild to moderate mild to moderate apnea and no comorbidities can treat with oral appliances. Those with any comorbidities such as hypertension, diabetes, obesity, heart disease should be treated with CPAP. And people that can't tolerate CPAP should consider oral dental appliances. And this is, again, the American Heart Association scientific statement. We're underdiagnosing it, and we should treat it. This is really a big problem. It's really an epidemic of the 21st century. Is this poor sleep because of apnea and other stimulations that we have at night, such as our iPhones and screens. So treatment's mild to moderate. That's AHI, apnea hypopnea index of 529. Oral appliances, if there's no comorbidities. If they have comorbidities or severe, they should be using a CPAP. That's the current treatment recommendations. Adherence. Well, compliance with CPAP is defined as using it about 4 hours a night for 70% of nights. So it's not treatment of 7 nights a week or all sleeping. It's just that the compliance defined as you use it about maybe half the time. And compliance is very low in all but severe apnea patients. People just don't want to use these CPAP devices, and severe ones will because their symptoms may be so severe. Obstructive sleep apnea implications. Again, about 20% of patients are diagnosed, even severe, very low. Compliance with treatment is low. So then why, other than sleep quality and quality of life, why should we be concerned if our population has obstructive sleep apnea? Well, if untreated, sleep apnea leads to hypertension, stroke, heart failure, diabetes, obesity, heart attacks, depression, cognitive impairment, motor vehicle accidents, brain shrinkage. There's actually lesions that occur in gray matter that can be reversed, and poorer quality of life. This is a 21st century epidemic. It's one of the things that we wonder, what's happened to us as human beings that we're getting heavier, we're developing more diabetes in spite of advances in medical care. Well, our lifestyles have changed as well, and we're just not sleeping as good. So why would an anti-aging practice such as ours be concerned about apnea? Well, in a study, 18-year study, University of Madison, Wisconsin, in a 20,953 person-year study, that's a massive study, they looked at mortality, death. So people with severe apnea had a 3 times incidence of all-cause mortality, 3 times the incidence. Now, they did adjust it for people that use a CPAP or not. If they use a CPAP, they had a lower mortality, but still is higher than the general population, generally because compliance is so horribly low. And this was independent of BMI, age, sex, or other potential confounders. So they found that it was 3 times higher, even when you adjust for the fact that if you said, well, patients who are obese are going to have more sleep apnea, even when they adjusted for that, it was 3 times higher than people without sleep apnea, which would be defined as an AHI less than 5. For those who were never treated, they saw specifically a 5 times mortality from cardiovascular disease, people with that had severe apnea over 30, and that were not treated, 5 times mortality. For people with mild to moderate apnea, 50% increase in all-cause mortality. And here's a graph they use. This is a Kaplan-Meier extrapolator for 20 years. So if they extrapolated 20 years, you can see on the left side there's percent surviving, and on the bottom there is 10 years follow-up. So the survival rate of patients who have severe apnea, untreated, is about 58% at 20 years, versus patients who do not have apnea, about 92% at 20 years. So this is very important that we have an ability to realize this impacts our patients' longevity. And even the mild and moderate has significant reductions in longevity if untreated. So with treatment, we see reduced hypertension, cardiovascular events and deaths, reduced depression and obesity. A study showed 5.5 pounds of weight loss in 4 months in a weight loss study for the treated versus the untreated. So they lost more weight when they were losing weight when they were treated for apnea. Improved quality of life, and brain lesions reversed. So there's actually lesions occur in the gray matter, particularly in people with severe sleep apnea. And we see these on MRI, and they are associated with cognitive impairment. People are really vaguely not sure why they're just having brain fog or not as having a sharper memory. And associated with sleep apnea, if we treat this, these will reverse in about a year. Dental appliances for mild to moderate without comorbidities, these definitely work. There's issues with compliance. Some people get dry mouth, jaw discomfort, they can get changes in their dentition and their bite. So some people don't like these for that reason, but that's a good alternative for somebody that doesn't want to do CPAP because they don't have comorbidities and they just have minor disease. They could use a dental appliance. See, there are many dentists that specialize just in doing that. The CPAP limitations, well, there's high non-compliance. It has a lot of side effects. I'm not going to list them, but I wore one briefly. I had a neck surgery back in 2015, a spinal surgery, and I got sleep apnea just because of the airway edema, and my sleep was horrible. And it was nice wearing that CPAP. I borrowed one from one of our staff members. Her husband had it. He wasn't using it. He had disease, but he didn't use it, so I used it, and I got to where I could sleep, and then I needed it for a couple weeks. But it was really difficult to wear that thing. It made my face hurt in the morning. My mouth was dry, but it let me sleep. So that personal experience using it for about 2 weeks. It doesn't reverse the condition. So you should do, if you have somebody on CPAP and we check their AHI score, it should get better. However, if they don't wear it, it goes back to where it's at, or it gets worse over time. It classically gets worse over time because this is a condition to aging, and it has to be done, forever. There's a procedure called Inspire. It's approved 2014 by the FDA. It's hit and miss if it's covered by insurance or not. It's a surgery. There's a implantable device, kind of like a pacemaker or defibrillator, goes in the chest, and the wire goes up to the hypoglossal nerve, and it stimulates the nerve so people move their airway at night and don't choke and don't have apnea. This has led to a 68% reduction of the hypopnea index, and half the people got a 66% or more. So whenever we see these reductions, you want to know, well, did it affect everybody? Well, most people that have more than 50%, so that's pretty good. The rate of serious side effects is 2%, and that's really a concern. 1 out of 50 people will have serious side effects that requires reoperation or even having significant morbidity. And the cost is $30,000 to $45,000. Hopefully insurance pays for part of that, but it's a very expensive surgery and device. NightLase, which is the Photonolase, it was originally developed for snoring. Okay, so in about 2011, 12, 13, 14, 15, 16, you'll see papers where they looked at shrinking the back of the throat, the pillars and the uvula, and they found that 2 treatments led to about a 50% reduction in snoring. It probably lasts about 2 or 4 years, maybe longer. I did mine in 2017, and I had some minor snoring. It really has never come back to that degree. But I didn't really test it. I didn't really do any tests to see how bad it was. So it's not a good indicator, but it lasts a long time. And it was just using the erbium YAG of the Photona on the back of the throat. And that's what we were using it for before. We never really did it for our customers because the procedure was really for snoring and didn't really have any known medical implications, and it just wasn't our bag. However, in November of 2021, paper was published, and I've been following this for a little bit, for about a year or two. They're doing a more aggressive procedure, which we've been offering since last year, with the NightLase 360, which is different in the fact that it uses both the ND YAG and the erbium YAG. So it's more similar to how we do the Lady Lays. Use both wavelengths. You pre-treat with the ND YAG to heat up, and then we treat the tissues with the erbium YAG. And it's not just the back of the throat, it's also the base of the tongue to pull the tongue forward, and the floor of the mouth to pull the tongue forward. For snoring, it should be a plan for 3 treatments, 2 weeks apart. And with this study, they showed that there was a 66% reduction in the apnea-hypopnea index, and 78% of people had greater than 50% reduction in $800 per treatment, so about $2,400. Now you can do more treatments, you can do less treatments, less will work less, and more treatments will work more. For the clinical study, they did 3 treatments, and 100% of people responded. The range was 34 to 100%. So the majority of people got more than 50% reduction, which has a big impact for quality of life. And the thing, when we think about this is versus a YAG versus a CPAP machine, is if you reverse your score AHI of 66% in this case of NightLase, or 68% in the case of Inspire, it's like that every night, all hours of the night, versus CPAP compliance is only using it 70% of the time, 70% of the nights, only 4 hours a night. So only 50% of use with CPAP versus 100% with this or with the surgery. Now, if we compare non-CPAP options, let's look at the Inspire nerve stimulator versus the NightLase, which combines erbium and the ND YAG. So on the left, we have an implantable hypoglossal nerve stimulator. On the right, we have a erbium YAG done 3 times. With the Inspire, we see a 68% reduction, and with the NightLase, a 66% reduction, almost the same. With the Inspire, for 50% or more improvement, it's about 2/3 of people. It's about 78% of people get the same response with NightLase. So NightLase is slightly superior, not substantial, but slightly. With the Inspire, there's a rate of serious side effects at 2%. That's concerning. With the NightLase, there's people have dry mouth for a few hours. And the cost for the Inspire is $30,000 to $45,000. The NightLase is $800 per treatment, so $2,400 to potentially up to $4,000 or $5,000. They need multiple treatments. I think some people might need 4, 5, 6, 7, 8 treatments, typically not more than that, but it can be based on their severity. So we can identify that if somebody has mild to moderate, that they should be figuring that they'll have about a 50% reduction in general after 3 treatments, and they could do additional treatments if they so choose. NightLase considerations, they probably need maintenance. We don't know how long this lasts. Like I say, with my case, I did it for snoring, and it's lasted 5 years. For people with more advanced disease, they may need to do it again in anywhere from 1 to 5 years. We don't really know. So it would be good to do a sleep study every year or 2 to see if they're getting worse. And it does reverse the Malpati score by about 1 to 2 classes. So there's a study there where they looked at the scores before and after, just doing the back of the throat, just the old-fashioned erbium only, and they found that you usually reverse people 1 to 2 classes after 2 treatments. So it does reverse the condition, but of course we continue to age, so there may be some maintenance needed. NightLase considerations, there's no insurance coverage, which is fine. We're in the non-insurance business. 3 treatments work on all patients, but the range was 34 to 100% improvement of the AHI score. So, patients may need more, and it is linked to severity. And people may do more treatments. Now, it's done every 2 weeks, but if they did every 4 weeks, it won't matter. Sooner than 2 weeks is probably a little early. They could do it later than that. They could do it every month. It wouldn't really matter. It's just additive.